Okay, good luck. Excited for this one. Thank you both.
Hello, everyone, and I'd like to welcome you to today's session. This webinar is part of our November prevention campaign, and today we'll focus on trauma-informed mental health care and prevention in children at risk, increasing resilience in traumatized children. A couple tips for today. Please make sure that you remain muted during the presentation so we can avoid background noise. Also, please introduce yourself to others, attendees, and the presenters in the chat box. We'd like to know who you are, where you're from. We will be going through a polling through a platform called Slido. So please have your phones ready, and you will scan a QR code to participate in this polling. You'll see questions come up that you will be allowed to answer on your phone. If by chance you're not able to use your phone to do this, please type your answers to the questions in the chat box, and one of our staff members would be happy to add that to the Slido poll. And as always within a SPCAN event, a recording of this whole discussion and any supplementary materials will be available on demand at the SPCAN website, but will also be sent directly to you in an email following this event. Our goals for today's session are really to look at one country's system of care around prevention. We'll examine the mental health of parents and children at various stages, highlighting tools that work and addressing challenges. And most excitingly, we'll invite the global dialogue around what works and the global challenges in treatment and prevention. At this point, we'd love for you to take your phone and scan the QR code that you see now. Once you've done that, our first polling question should come up. So please let us know what country that you are joining us from today. And don't forget to hit enter after you put your information in. And welcome to our friends from Canada, the US, Uganda, Japan, South Africa, Ireland, China, Botswana, Myanmar, Wales. We have a very diverse audience today, so welcome to all of you. We appreciate you joining us. Our second question is, what are you hoping to learn from today's session? Just a brief few words answered to help our presenters know exactly why you joined us today. We see that you're looking to know more about prevention and trauma-informed practice and best practices. Screening tools, tools for case management and trauma, practical programming options for us to implement, information to use for parents, that's a great one, to do less harm, evidence-based programs, some great answers. The focus on mental health. The acknowledgement that mental health is a crisis. Some ways to help that are meaningful. practical programs for us to implement, and current information about trauma. Thank you to everyone, and we hope that you gain insight and answers to all of these questions and challenges. Without further ado, I'd like to introduce our two presenters. Dr. Brooks Keeshan, who's a child abuse psychologist at the University of Utah and a child abuse pediatrician. Brooks provides trauma-informed psychiatric services at Primary Children's Center for Safe and Healthy Families, and he's the Associate Vice Chair of Child Mental Health at the Huntsman's Medical Health Institute. Dr. Keeshan's academic efforts focus on detecting and responding to children, adolescents, and youth at risk for traumatic stress and suicide. He is director of the Utah Psychotherapic Oversight Program, which is responsible for ensuring that all youth in foster care receive safe, evidence-based, and trauma-informed psychiatric treatment. Brooks is also the director of Pediatric Integrated Post-Trauma Services, a Category 2 center of the National Child Traumatic Stress Network. Also joining us, Dr. Lastina Kostova, clinical psychologist and director of training at the Lifeline for Kids at the Department of Psychiatry at the University of Massachusetts Medical School. With a multidisciplinary multicultural education obtained in Italy, Switzerland, and the US, she has a strong background in clinical psychology, and her main interests lie in the areas of childhood trauma and mindfulness-based intervention. Dr. Kostova is an international trainer in trauma-focused cognitive behavioral therapy, TFCBT, an MBC2 qualified teacher, and she's also a certified trainer for teaching trauma-informed curricula developed by the National Child Traumatic Stress Network, including the core concepts of childhood trauma and resource parents curriculum. On the research side, Dr. Kostova authored several peer-reviewed journal articles, contributed to book chapters, and presented to several international scientific conferences. Dr. Kostova is the NCTSN representative in Italy and Switzerland, where she is currently implementing evidence-based treatments for children and adolescents, collaborating with several universities and networks. And at this point, I would love to turn it over to Brooks and Lastina.
Well, Jane, thank you so much for that introduction. We are really excited to be with you all today, I guess, to this evening, this morning, whatever it is that it happens to be. Welcome, and really look forward to having a robust discussion. Can someone please let me know if I am sharing correctly, or do I need to swap displays?
We see your notes, Brooks. Do you want to put it in presentation mode?
Perfect.
Perfect. There you go.
There really aren't any notes. It's just a matter of actually whether it's big enough for you. So yeah, I think what we'd like to do, what Dr. Kostova and I would like to kind of facilitate is kind of a presentation that's going to have three main parts. First part, what is trauma and ACEs? Why is it important to distinguish the two? Second part, what are the main ways in which we treat trauma here in the United States? Detect trauma specific to other types of conditions, such as, and don't forget to mute if you're joining us and there's some background noise. How we treat trauma throughout the United States. And then third, I'll come back and present a little bit on, well, how do we identify those kids that actually would best benefit from trauma-specific services? So I do want to start off with kind of this, if I can get it moving. There we go. Kind of the definition from SAMHSA, which is really focused around what is trauma-informed care. This is not the only way to think about trauma-informed care, but I do want to kind of preface this as this is a predominant way that it's thought about here in the United States. And it follows these 4 R's, which in a lot of ways seem, I think, very simplistic to a child maltreatment professional group such as yourselves, but are important to recognize that, we have to realize that it's actually impactful. We have to recognize the signs and symptoms, and we need to figure out how our systems respond to those kids, but not just respond, but respond in an effective way. And doing so that actually helps those kids get back on track developmentally, and does so in a way that actually doesn't make things worse, that doesn't re-traumatize or cause added distress to the children and families we're trying to serve. And we're trying to do this in a situation where essentially, I mean, it is more common to experience trauma here in the United States than not. And that's, I think, a hard starting point that we have to have. That really, if you look at David Finkelhor and others' work, you find these percentages, but they're all north of 50%. That is more common to have experienced at least one potentially traumatic experience before the age of 18 than to not. And then of those kids who do have potentially traumatic experiences, they are the group that is most likely to have multiple traumatic experiences. So it's often, unfortunately, not a one and done type of situation. And there's been a ton of work that's gone into trying to identify both the experiences, but also the types of reactions that children have after a traumatic event, which has also left us to a lot of different language. And frankly, I think sometimes a lot of confusion around kind of who are we talking about? What are the symptoms that we're focusing on? What's the population? And so you think about kind of developmental trauma disorder, post-traumatic stress disorder, think about ACEs, think about child traumatic stress. I mean, you see all of these things thrown out there. And I think oftentimes a specific MDT, a multidisciplinary team, they may even within themselves be using words, either the same words in different ways, or they might be using different words to describe the same thing. And so what I'd like to kind of just start us off with today is kind of just to highlight at a very high level, what are we talking about? We talk about kind of trauma-specific things we're focusing on versus kind of the larger range of ACEs. And in a lot of ways, trauma is helpful for us from a medical standpoint, for those of us who are providing medical care for kids, because it helps us kind of get to what might be an appropriate diagnosis. And that diagnosis can then be linked to, well, what are the appropriate treatments that we know are effective for that specific type of reaction? Knowing that kids will react to trauma in lots of different ways, but that for specific types of reactions, we know that there are some things that work. And so we've got this pattern, and this is, I don't think it's fully baked yet, frankly. I think as you've seen the evolution of our understanding of trauma, traumatic stress, and PTSD over the years, I mean, it's important to know that we didn't even include kids in our understanding of PTSD early on. Like, they were resilient, they're fine, they just brush it off. But really, over the last 20 years or so, we've really come to a much better understanding of what does it mean to actually have PTSD in childhood. And for those of us who work in the child maltreatment area, I mean, this is really critical because, I mean, we know that there's at least 5% of kids in the United States at any given time that meet criteria for PTSD. And that really child abuse is both a predisposing factor, but it's also a precipitating factor for the development of PTSD. And of course, for those who already have PTSD from other types of traumas, it can be a perpetuating factor as well. And so when we think about kind of, well, applying PTSD to children, it is fraught with challenges because originally it really was an adult-centered focus around individuals who'd experienced war. And individuals who were survivors of sexual assault. And so how to apply that to the child maltreatment population has been difficult, but over the last decade, we've really, I think, done a much better job thinking about subtypes and really specifying what does it mean to be a child who has PTSD. And when we think about that group of kids, whether it's child maltreatment related PTSD or not, we're thinking about having had that significant, potentially life-threatening or serious injury or sexual violence related experience, right? That's a core experience that that child has either had themselves, they've seen it happen to someone else, or it's happened to a loved one, even if they weren't there. But it's that core fundamental experience that child has had, which might be a part of a series of experiences, or it could be a one-time event. But then the rest of PTSD, I think it's really important to kind of take a step back and think, it's not like there's all these bad things going on with this kid. It's not like they're a total mess, but rather there is actually a predictable, understandable flow to how that initial significant experience can start to impact that child or that adult. And it really starts with these core intrusive symptoms that in a sense, what happened to that child continues, that event continues to be bothersome to that child. to the point where they're either having memories specific to that event or flashbacks, which are more like it feels like it's happening all over again, even though it's not, or having nightmares or other scary dreams, or actually just whenever they are exposed to something that reminds them of the event, they have some type of either physical reaction or an emotionally distressing reaction to those trauma reminders. But that really is that core component of like, I had the event happen and now I continue to be bothered by that event. And so if we hold that together, as these are two things that are kind of, you cannot separate them apart, the experience and the reaction, then these other criterion that we often talk about make a lot of sense. Because if what happened to you continues to be bothersome to you, well, of course you would try to avoid people or places that remind you of the event. Or of course you would try to not talk about the event or not think about the event. If what happened to you continues to be bothersome to you, it's understandable that it's going to impact your view of the world. And it's going to impact your view of yourself, and probably not in a helpful or healthy way. That you're going to think more negatively about yourself or more negatively about the world, or not have the same quality of relationships that you had with others prior to the traumatic experience, that you're not going to experience that kind of wonderful range of emotions that we see in children and adolescents. And if what happened to you before continues to have that kind of intrusive, continuing to bother you sort of way, I mean, why wouldn't you be a little on edge? You know, as if you're still kind of in that setting that's fraught with danger. I mean, why wouldn't your body continue to kind of live in that state where you're a little bit more reactive to things, or a lot more reactive to things? And, you know, those are situations where we're not going to fall asleep so easily. We're not going to focus on things that are, frankly, a little boring, like school could be at times. And so, you know, as we think about this group, you know, I mean, there's folks who, you know, that's basically their experience. And there's folks that have that kind of experience and set of reactions. And also as a way to try to quell some of that distress, they actually kind of go away a little bit. They dissociate, they kind of can kind of zone out. And some kids and adults, this will happen to, others they don't. But that's also a really kind of well-described experience that we can see. And, you know, this is what's currently in the DSM as kind of the, you know, well, how do we qualify if this is happening with a kid? And in a lot of ways, we've simplified it for the younger kids. So we don't think about kind of the avoidance and the negative cognition and mood. That's the criterion C and D. We don't think of them separately. We kind of jumble them back together like they used to be in DSM-4. And with criterion E, that like reckless and self-destructive behavior, well, there's a lot of kids with emotional behavior challenges that have reckless and self-destructive behavior. So it doesn't help tease them out very well. But when it comes to kind of that idea of detachment, what we think about instead is we think about, well, are they expressing are they observably more withdrawn than before, which can be a sign of PTSD in these kids. And so when we think about kind of this construct, we have really good biological data to help understand how the stress response system gets kind of run amok, shall we say, in kids with PTSD. And so when you think about it, we have these clear phenotypes of after the experience, you know, these predictable types of reactions that we can define and capture. And then we actually we know that there's an underlying biology that helps explain what we're seeing from a symptom and functioning standpoint. And where this is different is that we also have a lot of work within the United States around adverse childhood experiences. And as you can see from this kind of list of some of the most common adverse childhood experiences that we talk about, this is actually from the original study that was done in the 1990s as part of the Kaiser Permanente study done in collaboration with the CDC, the Center for Disease Control here in the United States. You can see that this is a mix of things that are inclusive of traumatic experiences, but are not limited to traumatic experiences. And the way that the initial kind of theories around the impact that adverse childhood experiences had on individuals who experienced them is that it kind of resulted in some individuals where there was almost a cascading effect, where, you know, as a result of having these experiences, there was disrupted neurodevelopment. And among those individuals with some disrupted neurodevelopment, some of them would be the ones that they'd be more likely to develop social, emotional, or cognitive impairment. And of that group, that's the group that's more likely, not all of them, but more likely to develop high-risk behaviors, diseases, and then even going as far as to early death. And so there's been a lot of work over the last decade thinking about kind of, well, what explains that? And so toxic stress has been brought up as this concept of, with all of the exposures that people are feeling through adversity, that it really gets under your skin. It impacts everywhere in the body. And that when we see clinically in pediatrics or in young adults or in older adults, when they've had increased ACEs burden, we know that they are going to be more likely to be unhealthy in a wide variety of areas, but not necessarily limited to or specific to trauma and traumatic stress. And in a lot of ways, this has been, I think, one of the cruxes of what we in the United States have been kind of struggling with. Because, the data around this, the profound impact of ACEs, of all these different types of adversities that children face, are profound. And without the right buffering and the right support, they do all have this ability to kind of impact development and ongoing health in a variety of ways. But the challenge is, and this is where organizations like the National Child Traumatic Stress Network have really been a leader in this area, it's that, when it comes to ACEs, adverse childhood experiences, we know that not all ACEs are equal. We know that different types of adversities impact children in different ways. But we also know that we have a whole litany of evidence-based trauma treatment modalities that work, but they were not designed to work for ACEs-exposed individuals. And that's a clear distinction. So if I know that a kid has, quote unquote, a high ACE score, we know that they are elevated and they had a lot of exposure to lots of different adversities. That doesn't necessarily mean that they have traumatic stress, PTSD, or would benefit from evidence-based treatment. And conversely, if you have a kiddo who has a low ACE score, but they had one really bad ACE, they had a significant physical abuse experience, or they had a sexual abuse experience and they did not get help right away, or they did get help right away, but it was incredibly impactful to the individual. That ACE score of 1, but coupled with the information that helps us understand how that child or adolescent or young adult is reacting to their experience, that's really the connection that binds like the evidence and the treatment that we have with the types of things that we can afford that kid. So this has been an ongoing debate, and it is not over in the United States in terms of we have limited time in healthcare systems to identify kids who've had multiple adversities. And we are also trying to figure out how to identify kids for whom they've had specific traumas and might benefit from evidence-based trauma treatment. These are two kind of at times complementary notions, but oftentimes in a fast-paced world where we're really trying to kind of go quickly and be expedient, they can also be somewhat competitive with each other. And so what we're going to do is we're going to transition. I'm going to stop sharing my slides now, and we're going to spend the rest of our kind of didactic time talking about kind of, well, what are those treatments that we can do for those kids where we do identify trauma and traumatic stress? And then I'm going to come back a little bit later and talk about, well, then how to identify those kids in the first place.
Thank you so much, Brooks. I was told that Brooks is a very engaging presenter, and so that was absolutely a confirmation. And it was such a clear way to explain what is PTSD and how it works. So thank you for that. I will share my screen with my slides. Can you see my slides? Okay.
Yes, you're perfect.
Perfect. Okay, so I'll take it from here. Welcome everyone from any country that you're joining us. My name is Latina Kostova, and as Jane mentioned, I'm a clinical psychologist and also the director of training in one trauma center at the University of Massachusetts Medical School. So I am Bulgarian, which explains my accent, but I am located in Massachusetts. And I'm really delighted to be here. I love working with EastCan and all the great things that you are doing. And today I'm here in my role as an international trainer in trauma-focused cognitive behavioral therapy. And as Brooks talked beautifully about the importance of evidence-based treatments and how can we know whether or not kids need them, which he will address later, I would like to present you the most evidence-based treatments that we know for today, which is trauma-focused cognitive behavioral therapy. And this is my quick agenda. I know that in 20 minutes will be difficult to tell you everything about TFCBT, but I would like to start with a little bit of the evidence of the research in the literature that we know about TFCBT and how can be applicable to you. I would like to mention some studies that might be helpful for some of you. And then I would like to briefly explain and describe what are the main components of TFCBT, because I believe that TFCBT has a very clear framework and it kind of comprehends together a lot of the main stages that other trauma-informed care treatments have. And then I would like to talk a little bit about some of the data that we collected in our center here in Massachusetts about TFCBT and some of our efforts in implementing it around the world. So maybe some of you might be interested. I promise you, I'm not paid by the developers to advertise this model, but this was the first evidence-based model that I was trained in, and I've really seen how it works so well with kids and families, and so I truly believe in it. Now, I know that we are here with EastCan, which is an organization about prevention, and you all would like to know what can we do to prevent those kids to develop PTSD or even to be exposed to further traumatic events. Now, TFCBT was mainly developed as a treatment to help children who have been already exposed to trauma. It was actually developed mainly for children who are exposed to sexual abuse, but then the developers refined this treatment in the past 20 years, and now there is a lot of research showing that it works for multiple types of trauma. But I also hope that with my presentation, I can show you and convince you maybe that TFCBT can also work with those children who are in ongoing exposure of trauma, or children who might be at risk of experiencing some adverse events. And I also think that some of the skills of TFCBT, particularly the first part, which are the prac skills, can be also implemented in terms of primary prevention. Now, the most powerful, why I like doing trainings and talk about TFCBT is because really the most powerful part of this model is that it's the most evidence-based type of treatment that we know so far, really all over the world. There are more than 23 randomized controlled trials of this treatment that consistently shows and demonstrates significant improvements, not only in PTSD symptoms among children and adolescents, but also with comorbid diagnosis. As we saw earlier, children with trauma, they may present not just with PTSD, but with a bunch of other diagnoses, such as anxiety and depression. And so from many national and international organizations, TFCBT is considered right now the gold standard treatment for childhood trauma and one of the best practices that we know. So this is a map that the developers sent us a couple of years ago, and probably right now the blue zones will be even more, but these are the countries where TFCBT has been implemented. I am currently working in implementing TFCBT in Italy. We finished our first cohort last year very successfully, and then I will talk later about some other efforts that we're making around the world. Now, there are a lot of studies on TFCBT, and I promise I will not bother you with too much of data and research, but I wanted to select a couple of data that might be interesting for you. Now, I know that some of the myths about evidence-based treatments like TFCBT is that it can be provided and disseminated only by highly specialized mental health professionals like psychologists or psychiatrists. But there were a couple of studies that were done with TFCBT in some African countries like the Congo, Zambia, Kenya, Tanzania. And basically all these studies are showing that TFCBT, first of all, can be implemented with highly vulnerable children, right? So those children in these countries have been exposed to more than 4 types of significant traumas. And most of all, the TFCBT can be actually implemented not only in highly industrialized countries like the US or some parts of Europe, but actually in a lot of low resource settings. And particularly these studies were implemented, and they basically taught lay counselors, who are people with high school education, how to deliver TFCBT to children and adolescents, and there was a lot of success. One of the things, though, that it was really interesting in these studies was that actually training is important, and those lay counselors who are actually following the consultations, the supervisions, which are usually up around 1 year after the training, were those who delivered TFCBT and obtained greater outcomes. So training and supervision is really important. Now, another myth about evidence-based treatments like TFCBT is that probably therapists and whoever delivers this treatment has to be trained in CBT and has to have some knowledge about cognitive behavioral therapy. And my friend and colleague in Germany at Ulm University did this research, and they looked at some of the characteristics of the therapists in TFCBT, and if there was something in the therapist that actually helped in delivering TFCBT more successfully. And what they saw was that actually the theoretical background of the therapist didn't really matter. It didn't really matter if this person was trained in CBT or in psychodynamic psychotherapy. It didn't matter much their years of experience or their age. So I think that this is good news for those of you who are not trained, particularly in CBT. But there was one significant variable, which was gender. And I thought that that was interesting. And the research was showing that basically male therapists of TFCBT obtained higher improvements in symptoms. And one of the hypotheses that we were thinking was that unfortunately, most of the times when it comes, for example, to sexual abuse, most of the time sexual abuse was done by a male. And so for a patient who finds a male therapist who is actually predictable and safe and secure, that can be really helpful for a lot of the cognitive distortions that that child have had. So that's another good news for all the male therapists here among us, which are not so many. Now, again, talking a little bit about secondary prevention, and for those of you who are working with children who are exposed to ongoing traumas, another question is, can TFCBT work with children who are still exposed to some traumatic events, like, for example, the war in Ukraine, or children who are living in situations of domestic violence and the perpetrator is still in the house? And there are some, again, studies that are showing that TFCBT can also work with children who are exposed to ongoing trauma. And there are some strategies that are really important, such as, for example, starting with enhancing safety, so explaining to the child and the caregiver the difference between an actual dangerous situation and a triggering situation. Then the importance of effectively engaging parents. Most of the time, parents of children with trauma has their own ongoing traumas that can impact their parenting skills. And so really making sure that we engage the parent or any other caregiver that might be helpful for the child. And then approaching the trauma, the narrative component in a way that parents can be also aware of the ongoing traumatic stress for children, because sometimes parents might think that, you know, the child doesn't know actually anything about my fights with my husband, or actually the nightmares that she's having, it's not about that thing that happened, or the bombing that the child is hearing, or any of that. So there are some strategies that might be sort of adapted when it comes to ongoing trauma or re-traumatization. Of course, there is much more, which I'm not going to be able to cover here. There are many studies talking about TFCBT working online. There is a great research in Australia that TFCBT can be implemented in inpatient psychiatric hospitals with refugee kids, with sexually exploited children, and so forth. And overall, what we are seeing when we compare TFCBT to treatment as usual is that TFCBT has longer term effect. There are many of those randomized controlled trials looked at after 6 months or 12 months, if those kids still maintained their outcomes. The other piece is that TFCBT compared to other treatments, as I mentioned earlier, helps not only to the reduction of PTSD symptoms, but also about a lot of other comorbid conditions. And I think that the other strength of TFCBT is that one of those treatments that actively engages a caregiver. It doesn't have to be a biological parent. It could be a foster parent. It could be a social worker. It could be anyone out there that it's helpful for the child. But I think that this is really important because it can also help the caregiver around the child. Now, let's get into what is TFCBT. Maybe some of you are familiar with this model already. I would love to hear any feedback, maybe from those of you who have been already implementing TFCBT. And it's a little anecdotal because 20 years ago, when the developers created this model, initially they wanted to actually call it trauma-focused component-based therapy, but then for some other reasons, they decided to go with TFCBT. And I think that this is important because even though this model has a very important cognitive behavioral component, it also integrates a lot of other interventions, such as obviously trauma-sensitive interventions. There is also a lot about attachment theory, about family therapy, given that the caregiver is really involved. And from research, we know that TFCBT can be implemented with all children ranging from 3 to 18 years old. Now, from my own clinical experience, I think that when it comes to very little children, I'm not sure if the cognitive component might be easily implemented. I think it works a little better with a little older kids, maybe after 5 or 6, but there are obviously a lot of modifications that can be done also with very little kids. And we are also now implementing TFCBT with transition age youth. So we are seeing that it actually works not only until age 18, but up until 2021. TFCBT can be implemented in very different types of settings. It doesn't have to be only in a clinic, but it could be in school settings, residential settings, and also in a lot of different types of kids, youth in foster care, youth with developmental delays. There are specific manuals on the website of TFCBT, which I can share later, that deliver free manuals, for example, TFCBT for youth with LGBTQ youth, or kids with developmental delays or disabilities. So there is all this research out there. Now, in TFCBT, we like using acronyms, and the acronym of TFCBT is practice. So these are the different components of the treatment. And as I mentioned, at least for me and for most of the clinicians that I am training and supervising, what is really helpful of TFCBT is that it gives that framework. It gives that very clear sort of stepwise process. And so we start with a stabilization phase, which is basically teaching the child and the caregiver what are some coping skills that they can use to sort of deal with their PTSD symptoms or any other conditions that they have. And I think that these stabilization phase sort of skills can be really helpful also in terms of primary prevention. Those are things that we can teach to kids actually in the schools or any other settings. Now, the core of TFCBT, and I think one of the most powerful elements, stays in the trauma narration. After we help the child to learn some of the coping skills, we ask them to give us a narrative about some of the most terrible things that happen to them. And the reason why we are doing this with the child is because we want to basically break that link between the trauma memory and all the thoughts around it with all the overwhelming emotions, which is the reason why many children want to avoid talking about their trauma. And from my own clinical experience, I can tell you that it's really powerful to see how at the first time when you ask the child to tell you everything about what happened, their levels of stress are really high. But then the more they read this same episode, and the more sessions you're covering around that trauma narration, less their sort of PTSD symptoms and this overwhelming sense of emotions comes in. And then at the end, we end with the integration and consolidation phase. We have conjoined child-parent sessions where the child talks to the parent and reads that narrative with the parent. And this is also a very powerful moment when the parent and the child actually improve their relationship and they're able to have this reparative experience after the trauma. Now, with TFCBT, what we want to do is actually to have a balance. So we are trying to spend basically the equal amount of time in all these 3 stages. And in parallel, while we are doing and going through all these components, we are working with the parent. So if I'm working with the child teaching relaxation skills, I'm also seeing the parent and teaching the same things. And the other piece is that we want to do gradual exposure, right? One of the challenges in TFCBT for clinicians sometimes is that they have to make sure that at each session, even for 10 seconds, we are talking about the traumatic event, or we are helping the child to connect the dots between their emotions and their behaviors to what happened to them. TFCBT is relatively short to medium term treatment. It could be done between 8 and 16 sessions. But when it comes to more complex type of trauma, to more situations where the child had experienced sexual abuse and physical abuse and living in poverty, or where there is an ongoing trauma, we want to spend a little bit more time on the stabilization phase before jumping in the trauma narration and then in the integration. Now, just very briefly, to sort of show you the creativity of TFCBT, even though it's a manualized type of evidence-based treatment, people can be really creative about it. So we always start with psychoeducation, and psychoeducation is really very, very powerful. Usually the glory goes to the trauma narrative, but psychoeducation can be also really powerful for children, because this is how we start the gradual exposure. This is how we start talking about something that maybe this child never talked about, and maybe no one ever acknowledged or gave the vocabulary of what actually happened to that child. And during psychoeducation, we want to really normalize and validate all the symptoms that this child is experiencing, or the challenges that they're having with their relationships, with the way that they view the world and themselves. NCTSN, as Brooks mentioned, the leaders right now in this field, they have a lot of great resources for psychoeducation. There's some books, there's some handouts. I'm happy to connect with you individually and send you some of these resources, but they're really great. Once we did the psychoeducation, we jump into relaxation techniques. We know that children who had experienced trauma or who are at risk of trauma, they might go into this hyper arousal sort of mode, right, where some of the PTSD symptoms can kick in, or they may go in the hypo arousal mode. And so relaxation techniques are really helpful to sort of calm down that nervous system and to help the child to ground themselves. I'm also a teacher in mindfulness-based cognitive therapy, and so I know that mindfulness can be really helpful for adolescents, but we want to be really creative and make sure that we start with asking the child what actually works for them. Affect modulation is another of those initial skills that I think can be helpful in a variety of settings and different levels of prevention and intervention. And so here we are really helping the child to identify what are they really feeling. We know that children, particularly with complex type of trauma, they have difficulties understanding what they are really feeling, and then they don't know what to do about those emotions. And so here again, we can use a lot of creative tools, a lot of YouTube videos, even emotional thermometers, to help them realize how does my anger look like? How does my anxiety looks like? What are the situations that are evoking those emotions? And what are some of the coping skills, some of the things that I can do or the adults around me can help me doing to sort of get myself back to my own window of tolerance. As I said, even though TFCBT is very integrative type of treatment, the cognitive component is really important. And so we are teaching the child how to really connect their emotions with their thoughts and their behaviors. And even though it might be difficult to challenge right away some of the cognitive distortions that they might have been developing or some unhelpful thoughts, what we really want to do with the cognitive piece is to help the child to develop a major cognitive flexibility. So not to think in those black and white terms, but to really help them see that there is some middle path and some green areas. By the way, a lot of the resources that I'm showing you also are coming from the Medical University of Southern Carolina, and they are the biggest center disseminating TFCBT online. And so they created a bunch of online resources that you can download for free as well. I already talked a little bit about the trauma narration and processing, which is really some of the most distinctive features of TFCBT. And again, it's up to the clinical judgment of the therapist providing the treatment and the types of settings, whether or not you would like to do the trauma narration and in what way, if you would like to engage also the caregiver. But it's really, again, the goal is to undo those connections between the thoughts, between the reminders of the traumatic event and all the overwhelming emotions. So we are creating this sense of desensitization, and the child discovers that what happened to me doesn't necessarily has to identify who I am, but it is a piece of my life story, and the more I can talk about it, the less sort of triggered I feel. The conjoined parent-child sessions, this is where we are inviting the child to share the narrative with the parent. And we do this for a variety of reasons. Sometimes parents, when trauma happens, they may have an invalidative reaction to the child because that parent themselves are upset or anxious. And so with the conjoined parent-child sessions, we're also giving the chance for that caregiver to provide this corrective reaction and experience with the child. And again, this is really powerful to see how during those sessions, actually the parent and the child after that are much more able to connect and to talk about this. Enhancing safety is a component that we usually do at the end of TFCBT, but in complex types of trauma, we move this component a little bit at the beginning, and I'll be happy to talk about it later, but I think that this is something that, again, can be used in terms of primary prevention, teaching the child what is body safety, what are okay and not okay touches, what is a secret that it's a surprise secret versus a scary secret, who is an adult that it's a safe adult. If you get lost in a mall, who would be the strangers that you would go to ask for help? Again, from the same telehealth outreach program that I mentioned earlier, they developed great resources about helping the child maybe think about what are the qualities of good friends and what are some warning signs in friendships or romantic situations, right? So all these type of different strategies that we can use based on the type of trauma that the child might be exposed to. I know that I'm probably running out of time, so very quickly, I would like to talk a little bit about our training, our trauma training center here in Massachusetts, and what we are doing in order to disseminate evidence-based type of treatment. And again, I'll be happy to answer more questions later. But what we are doing is really training a bunch of professionals in our state about trauma-informed care, and we are the biggest center in disseminating TFCBT. And we also have this centralized referral system that is helping to connect children and families who have been exposed to trauma to evidence-based treatments. Just to give you some numbers, we had trained over 14,000 professionals for our first grant cycle. We are also funded by SAMHSA, and we are members of the National Child Traumatic Stress Center. And now we are at the second grant cycle. So the data that I will present you are from some years ago. But we basically did this research study involving over 300 children and youth who received trauma-focused CBT. And what we saw was that, first of all, these are some of the main type of traumas that children were exposed here. You can see that some of them are traumatic loss, impaired caregiver. By impaired caregiver, we mean parents who have some addiction problems or who has some significant mental health conditions and so forth. And what we have seen in our, again, own site is that after TFCBT treatment, children significantly reduce their PTSD symptoms and also their internalizing and externalizing behavioral problems that were coming along with trauma. And what we also see is that both children and parents improve their social connectedness after the TFCBT treatment, and that parents actually felt like they were less stressed out after they received TFCBT. Last, some of the current efforts that we are doing right now, we are implementing TFCBT in Ukraine. We started doing online trainings with a lot of therapists. Our goal is to reach over 200 therapists in Ukraine. And I think that this is really great and it's working really well so far. And I am personally implementing, as I mentioned, TFCBT in Italy. So for those of you who are interested in any training, I'll be happy to facilitate that. And so just to end, I would like to say again that TFCBT is obviously not the only one evidence-based treatment, but it's a pretty good one given all the research data. And again, I think the power of TFCBT is that can help not just PTSD symptoms, but a lot of other types of conditions. And it can also improve the resiliency in kids and their caregivers. Thank you so much. I will stop here because I know Brooks has some more slides, and I'll be back after.
Great. Thank you so much. That was really a wonderful overview, and I think really sets the stage nicely for kind of this last part of our presentation, which is really focused on kind of, okay, so if we know that those kids are out there, and we know that there are things that we can do to actually help them get healthy again. What do we do to kind of connect, to foster that connection, to enhance that connection? How do we make it more likely that the kid who needs something like TFCBT gets TFCBT? And really both from a prevention or early addressing of PTSD or other traumatic stress or trauma reactions related to their child abuse or other types of traumas, but also from that very early point that if they've had a traumatic experience, if they've had experienced victimization, they are also more likely to experience subsequent victimizations. And so those key components, not just in terms of reestablishing emotional regulation and parent-child relationships are so critical for that kid, but also in reestablishing safety for that kid, so that we're actually thinking about preventing the next episode of childhood trauma or child abuse as part of evidence-based trauma treatment. So I'm going to just jump off real quickly. Are my slides going again? Is that okay? Working? Okay, thank you. Thank you. So just to kind of reiterate, so we're starting off with this place that there are evidence-based trauma treatments out there. TFCBT is the most studied of all of them, although there are other ones that are there that if you might have in your community or in your country can also be utilized. And I'm just going to reiterate the practice components because it's going to come up later in my slide, and my slide's slightly different than Dr. Kostova's slide. So, but just to kind of as a place mark, like there are components to this evidence-based trauma treatment. So what we did in our center was like, we have a lot of kids who came to and received TFCBT, but we were not the first stop for them. They were abused kids, yet the Child Abuse Treatment Center was not their first stop. And that was frustrating to us. And likewise, we also had kids come to us who had a history of child abuse at some point in their life, but frankly, did not need trauma-focused treatment. They really didn't have traumatic stress symptoms, and they might have had some anxiety and depression or behavior issues, but they really weren't related at all to their experience of childhood trauma. And this was frustrating to us because really we wanted to make sure that we were meeting the needs of those kids who needed our help. And so we actually got a grant through the SAMHSA to be part of the NCTSN to try to figure out, okay, you've got all these kids who've experienced traumatic events, right? And you've got this whole world of mental health professionals out there. But like, how do you actually narrow down the kids who've experienced trauma, or even better, the kids who've experienced trauma and have reactions, symptoms, emotional challenges related to their trauma, and not connect them with any mental health person, but actually connect them with the mental health persons who are specially trained in doing evidence-based trauma treatments, such as TFCBT. And also, in the meantime, can we do something to help that kid today? So remember that last piece. So can we do something today that's consistent with what they will be getting when they come to TFCBT? And so we kind of looked all over the place, like, how do we identify these kids? And if you look at some of the kind of the standardized screens that are out there, they're either overly long or overly short, frankly. And you think about the complexity. I spent 10 minutes going on and on about all the different components of PTSD. Like, that's a lot of time. And if you're trying to think about in a child advocacy center or a primary care clinic or another non-mental health setting, we don't have the mental health expertise. And frankly, we don't have the time to go through all of those different types of things with every single kiddo. But I hope that you're already convinced that just knowing they've had a traumatic experience isn't enough information in and of itself, because it has to be the marriage of that traumatic experience with reactions, challenges, symptoms that are related to that experience, either directly or closely, but indirectly. And frankly, we have to do this in a situation where a core concept of trauma is avoidance. Like, it is not like we have folks that just come in and they kind of raise their hand and say, hey, I'm a child abuse victim. I'm a child abuse survivor. I've experienced child abuse. Like that's just not, I mean, if that were the case, then our diagnostic criteria of PTSD would be wrong, frankly, because avoidance wouldn't be a core component, but it is a core component. And I think in a lot of ways in our system, we also have a bit of a shared avoidance. Like, even those of us who are in the trenches working every day with child abuse survivors, oftentimes there is a desire to not necessarily go
Hi, friends. How are you?
how the child abuse
the color,
is
right?
impacting the how there's a desire on our part to not go to that place as to how the child abuse is impacting that child today, because that's another emotional injury that we have to carry as well, especially if we don't feel like we have the tools necessary to respond effectively now that we own that knowledge, now that we are holders of that knowledge. So we created a whole model, and I think we put in the chat kind of the link to where the model is. It's something free that folks can use. If you end up using it, we'd like to know, because then we tell SAMHSA, and SAMHSA, the federal government, likes to know when things like that are happening. But essentially, we designed a way in which non-mental health settings, focusing primarily on high-risk child abuse center-like settings, like we call them children's advocacy centers here in the United States, or in other settings such as primary care settings, how they can identify and respond to these kids appropriately, focusing mostly on the older kids and adolescents. And it's based on including a screener, but it's not limited to the screener, because it's really a whole process that we're talking about here. And it's a process that leads to a specific pathway that has kind of readily kind of identifiable concrete steps that a provider, a healthcare provider, or other professional can step. You do not need to be a mental health professional to do this, but really ensuring kind of these three main core constructs that need to be addressed in any older child or adolescent where you know that they've had a traumatic experience, which are very simply like different than screening for anxiety or depression. Like, one, they've had something significant happen to them. Are they physically safe? And this is something that those of us in child maltreatment world, I think we're pretty comfortable doing, but it's an important reminder that that has to always be the first step. Are they safe from the world around them? And then the second step is, are they safe from themselves? And I'm going to talk a little bit later about how we go about doing that and what we mean by that. We talk about non-suicidal self-injurious behavior and suicidality. And then the third step is, well, how do we actually use the child's own data, their own information, their own experience of reacting to their lived experience, and use that to inform what the right next step is? And by the way, can we do something today to help that kid? And that's really kind of the model that we came up with. And this, I'm going to fly through this very quickly. We have lots of trainings on this. Oh my gosh, I think I'm losing my video. Let me just see if I can stop and start that again. We have lots of trainings on this that are available. And again, happy to help from an implementation standpoint with different sites in different countries. We currently only have this in English and Spanish, but have worked closely with the developers of the screening tool. And so certainly I think about other languages would be possible as well. But to get to the core points, we use this screener to kind of identify these first two steps and kind of as a reminder of kind of with this open-ended question, has something significant happened recently or in the past? And the child can answer it yes or no. And then going on to the question, which in our system, we use an initial suicide screening question, which is just taken from the PHQ, the Patient Health Questionnaire 9, which is a standard depression screener here in the United States. And we use that as the first step of our suicide screening question. As you can see here, it's not the world's best suicide screening question, but it kind of gets to that idea of not wanting to be here or hurting oneself in some way. And so with this information, you can already make the two most critical steps: keeping that kid safe physically from the world around them, responding as we know we have to do when it comes to child maltreatment or other significant traumas that the kid has had, and then also to effectively respond for suicide risk. And so every place we go and we train on this model, we end up actually training on how to teach non-mental health folks, which could be a pediatrician, could be a nurse, it could be a victim advocate, could be the director of a small center that sees abused kids in rural Utah who has no training other than they're the director of the center. But we treat them to figure out how to triage kids when we identify that they're suicidal. And we use the Columbia Suicide Severity Rating Scale, which is really just a fancy way. It's a validated approach to kind of just highlight and identify there are kids who might have some suicidality, but it's really passive only. They're kind of wishing I were dead or just wishing I didn't wake up. But I don't have any active idea as to how I would hurt myself. I don't have any plan, and I certainly don't have any intention of doing anything. And it's highlighting those kids and separating them out from those kids where they do have an active idea as to what they would do. They do have some plan, and they do actually have an intention to do it, or they recently tried to kill themselves recently. And that's where kind of we can get any type of professional as part of the system to be an active player in helping to keep that child safe by helping figure out that stratification. And as you can see here, you've got kind of, this is where we kind of do this profile of, okay, these are the high-risk kids. This is where we do need to bring in someone to help with safety planning, right? We do need to figure out and see what is the right safe situation for their environment. When we look in primary care, it's interesting. When we do screening for suicide in primary care, what we find is about over 2/3 of all kids in primary care, non-child abuse settings, but just primary care settings, when we ask about suicidality and ask about traumatic stress, over 2/3 of those suicidal kiddos have high levels of traumatic stress. And most often we don't know about that because we're not asking. So it speaks to how connected suicide and traumatic stress are in this population, which is why it's actually part of the initial response model. We haven't even tried to refer this kid to Dr. Kostova's clinic yet, but we've already addressed two critical pieces to trying to keep this kid safe and to get them on a road to recovery. Once we've identified and we responded to their suicidality, then we're using their own data. And this is based on the UCLA PTSD Reaction Index brief form. And what we've done is we've modified it to be actually practically useful within a non-mental health setting. So we can do two things. One is we can start to stratify kids with a lot of traumatic stress symptoms. Those are the kids that even if they are doing well, we want to get them to someone who can do an evidence-based trauma assessment and ideally evidence-based trauma treatment. And to stratify those kids from kids who have low trauma symptoms. Now, low trauma symptoms doesn't mean, as Dr. Kostova very clearly articulated, that they don't need trauma treatment. And so we still take a functional look at them, and it still might be the right step to refer them to evidence-based trauma treatment, but that might not actually be what their right next step should be. And then kind of thinking about how to use this gradated approach. And, it's not meant to be a hard, fast rule, but it's meant to help a non-mental health person figure out how to work in partnership with the family to effectively stratify and figure out, well, what's the right next step for my kid? Or what's the right next step for me? And to use the child or the teenager's own data to really lead that conversation and not a kind of a one-size-fits-all approach. And then the fun thing, and this is kind of our added on stuff, we didn't think people would actually do it. And as it turns out, among folks who are non-mental health professionals, some of them actually like playing in some of the mental health things, even if they won't admit it. We actually took some of those core concepts of the prac skills that Dr. Kostova talked about, and we built them in a healthcare setting. They could be psychoed and some initial interventions. In a non-healthcare setting, we're talking about education, but doing it in a way that doesn't take the place of trauma assessment and trauma treatment like TFCBT, but rather is complementary to what one would be doing in their first session or first couple of sessions once they get to the TFCBT provider. So thinking about that in resource settings where there's not as many resources we would like, we're thinking about wait lists, we're thinking about kind of some of our light touch approaches or developing a tiered system of responses. Essentially what we're trying to do is we're trying to build in some of those initial prac skill components and being very targeted to specific symptoms that kid is having, knowing that for those kids who definitely need evidence-based trauma treatment, we're going to get them there. But for those kids who may not end up needing or may not have access to evidence-based trauma treatment, we're still going to get them something that will be helpful. And so at the end of the day, and this is something that can be done in a lot of different ways in a lot of different settings, but we put a lot of work on the front end to try to prepare ourselves to be able to identify and respond to kids. Because if we do that work ahead of time, then it's not like we're trying to be a mini mental health clinic, but we actually don't have to recreate the wheel every time. And so in our settings, we use different apps, different tools. We don't try to do something different for every kid. We really try to do the thing that's targeting what's most challenging to that child or that family. And oh no, cancel navigation. My screen just said to do something. Can you all, have I lost?
It appears to be working, Brooks.
Okay, great. It's frozen for me because I can't get it to move anymore. Okay, there we go. Just to highlight what we do in primary care, as one example of this, when we do screening in well child visits in kind of a, an urban, suburban primary care setting, we identify, I think, was that a motorcycle? I really think we had a motorcycle. We identify a lot of kids that we didn't know about that had, oh, that's me. I don't know how to stop that. This is the breathe video.
Oh,
I've never had this happen.
Can you close that window maybe that you have playing the video?
I'm going to work on that.
Okay.
Actually, it's a very catchy song, and it's very nice example of a relaxation technique.
So we'll literally play this in clinic with the kid. And I'll put my hand on my belly and I'll have the kid and the parent breathe with me. And it takes 2 minutes to do, literally 2 minutes to do. So that was totally unintended, but that's an example of what I'm talking about in terms of taking some of those practice skill components and actually putting them in a setting where we can really do something about it that's not in conflict with what TFCBT is all about, but really it complements and frankly, in a lot of ways, I think enhances the motivation for the family to engage in moving forward with a trauma assessment and evidence-based trauma treatment. Like, it takes away some of that mystique, some of that kind of, oh, that's a weird type of thing. I don't know if I want to do that. It's like, well, sitting here with your pediatrician, and we're going to play this video, and everybody who listened to that will have that song in your head the whole rest of the day. Like, that is part of what we do in TFCBT. So that's been our work, and really trying to both not send every kid who's experienced a trauma to trauma assessment and treatment, but at the same time, really trying to figure out novel ways to identify and respond to those critical needs of those kids early on, and to help to motivate and encourage and facilitate the engagement of kids who experience trauma and have a lot of trauma symptoms, to be able to connect those with the evidence-based trauma therapist who can be most helpful to them. I am not going to try to put my PowerPoint back on. I think we can just go to the poll and have a bit of a discussion.
That sounds great, Brooks. Thank you so much. I love the video.
Yeah.
So for those of you who joined us late, we would like to go through a polling process now. We're going to, the way the second half of the session will work is we're going to open it up to a Q&A process where we are going to really encourage you to unmute, raise your hand, unmute, and really ask your questions or make your comments directly to Brooks and Latina. But in addition, we'd like to kind of share some questions they had for you as an audience. So if you can get your phone and scan this barcode, this is different from the first barcode, so you may need to rescan from earlier. And the poll should pop up on your phone. And the first question that the presenters have for you is, how confident are you in providing care in a trauma-informed manner in your practice?
So some folks feeling very confident, but certainly sounds like there's a wide range on the kind of the, I think I do a little bit, but maybe not as much as I could.
Okay, yeah, very interesting. And I think somewhat confident is a great starting point.
Yeah.
From what you presented today. And then our second question, what are some barriers that you faced in providing trauma-informed care in your practice? This may answer the question of why we're somewhat confident. And you can enter as many answers as you'd like. Lack of information. I'm sure
Yeah,
the time yeah.
piece is critical. I mean, that's why with a lot of our screening, it's got to be 2 to 3 minutes, no more.
And the answers that appear larger are the ones that are submitted multiple times. So you can tell that there is a consistency in some of the issues.
Knowledge, lack of training, appropriate facilities.
Are any of these a surprise to you, Brooks or Latina?
Yeah.
I don't think so. I see the lack of training, and training being a big piece, which is what we are funded to do. So I think that it's not a surprise, unfortunately, that there is still lack of training and needs for more training all over the countries.
And interesting, you take all responses that mention time. I think you would see that probably being in the center of all of this.
I'm actually surprised there isn't more money, because that's often a funding resources issue is another big barrier.
I'm also seeing culture and cultural conflicts coming up. All right, I'd like to move on to the next question. Thank you for all your responses. This is a great starting point for our Q&A. So our next question, what are the main evidence-based therapies that are disseminated in your country? Latine, is there a difference between TF-CBT and CBT?
There is, in a way that TF-CBT is more, we use cognitive behavioral techniques in a trauma-informed way, right? So we always do this gradual exposure talking about trauma, while just CBT, it doesn't have to be necessarily trauma-informed. So that's an interesting, and I see EMDR, which is definitely one of the competitors with TF-CBT. There is also research comparing the two of them, and I know that EMDR, particularly in Europe, I think it's really broadly disseminated. So
Is there a fundamental difference between those two?
there is, yes, definitely. There is. I am not a trainer and I'm not trained in EMDR, but they use slightly different techniques, you know, of the processing of the trauma compared to the TF-CBT. So definitely there is. And the other piece is that EMDR doesn't really engage the caregiver necessarily, and there is not much evidence about EMDR with children and adolescents. But
Thank you.
it's also a great type of treatment. DBT, I see also, which is more for more suicidal, borderline type of individuals.
I see a lot of sand play and toys,
Right.
therapies, too much medication.
Yep. That's a tried and true approach, not effective, but certainly tried.
I also see ARC, which is another trauma-informed type of treatment, which is attachment, competence, self-competency, and regulation, which is a great treatment, by the way, mainly disseminated in the US and probably Canada, a little less so in Europe, but it's getting there as well.
And a couple of folks have mentioned CPP, or child parent psychotherapy, an evidence-based model out of San Francisco that really works with the parent-child diet. It's focused on young kids. It's wonderful to see that there's folks that are aware of it and using it in their settings.
Absolutely. This is a great intervention. And when I mentioned at the beginning about TF-CBT with very young children, I actually wanted to say that other treatments like child parent psychotherapy could be actually a very good intervention for particularly young kids between 0 to 5. Meditation, I'm glad to see that there is some meditation as well.
And then our next question, our final question before we open it up to a Q&A, is what are some challenges that you've encountered in using evidence-based therapies in your practice?
This should be blank because nobody ever has challenges.
I have a feeling we're going to see some of the same challenges that we saw in the other slides.
Stigma, definitely. This is why I started with some research studies talking about some of the myths about evidence-based treatments, that people think that they're just cookbooks. But I think that there could be a lot of creativity, lack of time. Absolutely. TF-CBT is an extensive type of, when it comes to the training, it is a 3 days training followed by almost 1 year of supervision calls and consultations. So definitely it does require some time.
And I think it's really important to know, I mean, so here in the United States, the licensure of mental health professionals predates a lot of the evidence that we have and the use of evidence-based treatments. And I think one of the challenges we have is that you can be licensed to practice mental health in a state in the United States, and there is no requirement that you do anything that's evidence-based. And the initiative, the desire, the drive, oftentimes has to come from that therapist, or the therapist, the psychologist being part of a team as a, well, this is what we want to do. We have values that say we want to use things that science says makes kids better. But that's not a requirement when it comes to licensure. And I think as we think about, well, who are the stakeholders to advocate for mental health professionals providing treatments that the science shows works, it's really beholden on all of us, as folks, whatever are, it's not just up to the mental health professionals to make this happen. Like, as stakeholders, whatever role we play in working with abused kids, like, we need the ones saying, hey, we need this specific type of treatment. Who can do that for us? Or if we don't have folks in the community that can do it, how do we start to train up? How do we start to incentivize, promote the utilization of evidence-based trauma treatments? Because that's what our kids need. And we have good science to show that not only is that what they need, but that if you compare that type of treatment to treatments that are non-trauma focused, non-evidence-based treatments, that they don't do as well. So I think that there is this kind of, sometimes there's this apathy, oh, we can't do anything about it. Like, well, actually we can. And, in our state, in Utah, we are a good example of, like, the pediatric hospital said, we're going to follow the science. And, we have trained over 1,000 providers over the years in TFCBT because we just made a commitment to make it work. But it wasn't until, like, we had grassroots advocacy, we had leadership involved, and then we were able to start, changing the paradigm of, well, they're just going to get what they get, to no, at a population level, we can actually have an impact on this, and we really have. And I give the trainers and the leadership a lot of credit to moving that forward.
I agree with you, Brooks, and I think that dissemination of evidence-based treatments, it's not an easy task, and depending on the culture and the country, I know as an European that there are, for example, one of the challenges that we had in Italy was that still Italians are very much psychodynamically trained, and so there is a stigma when it comes to cognitive behavioral therapy, and so it does take a while to sort of introduce also those models in different countries.
Thank you to both. And what a great way to lead into our open discussion. I see Jane West. Would you like to unmute and ask your question?
Sure, I'm coming. Whoops, my head's cut off. Okay. Hey, everybody. I'm one of the people that put down CPP, and my focus is I am an early childhood mental health clinician by definition. And if you're taller than I am, I won't see you, is my adage. I'm 5'2", so you get the idea. And I'm wondering, with all these fantastic protocols that you have, so kids are not left hanging while we hope they get a treatment, why, knowing CPP and that we can do that work, why that 0 to 5 area isn't showing up in your protocol around let's try, some relaxation or some of the pieces of the therapy that was presented today. Because I think, and also cognitively, I think we do believe that we can do quite a bit of work with young children below age 3 even. I know I have. So I guess I'm just wondering why perhaps there's a barrier, it still feels, to connecting the dots in the pediatric clinic and elsewhere, while we, there aren't that many people trained in CPP and others, but while we know the child is symptomatic. Is that question clear enough?
Yeah.
Thank
Do you
you.
want to go first, or do you want to?
Very good question, Jane, and I'm glad that you jumped in, because in our clinic, in our center, we have this centralized referral system that we're basically, as I mentioned, connecting children, adolescents to any type of evidence-based treatment. It doesn't have to be TFCBT, but what we are finding a big challenge, and I would like to hear Brooks what he sees in his clinics, is that there are not so many therapists who are actually trained to work with very little children between 0 to 5. Actually, CPP is a great model, and we are so much struggling to find therapists that are trained in CPP or any type of mental health professional that it's confident to work with very little children. I think TFCBT, because it does have quite an important cognitive component, sometimes it requires a little bit more of a creativity, you know, and training to translate those components to very little kids. But at least in my experience, we do have this difficulty to find enough trained clinicians with little kids. But that's a great question.
And I want to say something real quickly, but I want to get to Mark's question as well. So Jane, thank you for raising that question. Couple of things. One, we didn't include 0 to 5 in our group because it was too hard to include it. And we wanted to get something done and not let the perfect be the enemy of the good. So it's not that we're ignoring or avoiding the 0 to 5, but part of our initiative was to try to figure out how do we stop misdiagnosis. And when you think about the medication usage, especially among kids with maltreatment, it's an issue in the younger kids, but it's a much worse issue in the older kids. So having a way to try to at least create a frame and an easy trauma-informed lens so that we could see, okay, trauma is really the player here. Let's not go down the pharmacotherapy pathway. That was part of the goal. Additionally, we wanted to use a validated brief trauma symptom screener. And so we used one that was available. Alicia Lieberman actually collaborated with the folks who developed the UCLA PTSD Reaction Index to create a young child form, but that is still in process of being validated. And then that's going to be way too long for a primary care setting. So I think hopefully we will figure out how to make strides to quickly identify in non-mental health settings kind of trauma-specific needs of those younger kids. But what we've been focusing on is trying to use other types of risk screeners. So screeners that look at social terms of health, ACEs, or utilizing Howard Dubowitz's SEEK screener, which also is kind of a risk stratification tool, just to identify what are some of those younger kids that we should be having a greater focus on, knowing that we have a lot more to do. And so we're working on it. But yes, appreciate the question very much so. And Mark,
Thank
did you want
both of you. I was going to say, Mark, do you want to unmute and ask your question?
Yeah, sure. Thanks. Thanks for this. This is very helpful. So my background's in the neurosciences, and I work in schools both in the U.S. and also in Kenya, and also in Kenya, also working in children's homes or orphanages. My question is a combination of both the screening issue, but also how to differentiate the type of adversity the child experiences and when, in terms of the impact on the development of both neural, autonomic, and immune systems. I think what I'm finding in certainly schools, but also in the work in Kenya, is that the term trauma is used in this umbrella term fashion, not recognizing that, for example, a child growing up with severe neglect or deprivation manifests quite differently than a child that's been physically abused, and a child that's been physically abused manifests differently than a child that's been sexually abused. Now, obviously, there's often a lot of comorbidity of those adversities, but in cases where they're distinctive and there's not a whole bunch of the ACEs, you see different patterns of development of what's affected and when. So I guess what I'd like to hear is how you're thinking about the therapy in light of the type of adversity. And then I guess the underlying piece of that is, given the challenges that the ACE screener has had of being misused as an individual screener, which it was never designed for in the first place.
Yep.
Why is that any different as a warning than the types of screeners that you're using?
Brooks,
Maybe
go
I'll
ahead.
start with the screening piece, and then
Yeah.
you can. So specifically the screening piece, we don't predetermine what counts as a trauma. So we very much intentionally give a stem as to what types of things could be traumatic, but it's self-determined from that individual what they consider to be significant traumatic experiences they've had. So we went through a lot of process of well, are there certain types of traumas we should ask about? Are there the ones that you have to have? And we ended up kind of saying, well, on the non-mental health initial screening side of things, we were just going to kind of make it more self-determined. So if I gave the impression that we were just focusing on one area, I mean, that we've gotten a lot of criticism, folks who want to know how many of their certain trauma is captured, but we actually intentionally don't do it because it doesn't necessarily help the next step process and determining which kids are the ones that would be best suited for specific trauma treatment. And then I think when you talk about the specific types of trauma reactions or constellations of trauma reactions you have related to the different types of trauma exposures, I'm going to hand that off to my colleague to talk about kind of how that gets incorporated and how a model can actually be very flexible to deal with the different types of reactions that kids have. Does that sound okay for you to?
Sure. Mark, is this your question about the treatment? I just wanted to understand well what you were asking about the treatment itself.
Yeah. So the question is really, I mean, so for just to be concrete, I mean, so with neglect, for example, you get a severe blunting of the cortisol stress response, whereas in abuse you get a hyperactivation and you get, you know, hyper dysregulation. And so those are totally two different
Right.
manifestations, in the same way that a lot of studies have shown that in sexual abuse, if you look at kind of the response to fear, you often get a complete, you know, fainting or a deadening, right, in response to sexual abuse, which you often do not necessarily get with physical abuse. And so the manifestation, and we, you know, kind of understand quite a lot about that neurobiologically, neurophysiologically in the autoimmune system. It's how does CBT or whatever form of therapy, how is that sensitive and customized to the specifics of what is changing as a function of the adverse experience that the child had?
Very quickly, because I know that we are out of time, and I'll be very happy to follow up with you on that. I think that as Brooks convinced us, screening is really fundamental, and this is what we are doing. And I think that TFCBT or any other type of treatment is not just one size fit type of treatment, but it's really important to understand where is this child at? Is this child presenting with more hyperarousal symptoms or hypoarousal symptoms? And how can I really tailor each of those interventions, whether it's relaxation or psychoeducation, to the specific presentation of that child? So if I do mindfulness with a kid that it's more in the hypoarousal state or more, you know, dissociative or anything like this, I will do much different interventions compared with another one. But as I said, I'll be happy to follow up given that we're out of time.
And I think we have shown that even on the screening side of things, what we've been shown is that we can actually differentiate kids who are having predominantly sleep issues, which does transcend lots of traumas, but can be more prominent in kind of sexual related traumas, depending on the context. We can also be very specific in responding to the more that hyperarousal kind of kiddo, but we can also be very specific in terms of that kind of withdrawn, avoidant kiddo. And so even at that very basic level, which isn't at the refinement that you're describing, I think we're trying to show that we don't have to just like, oh, trauma kid, we'll teach him belly breathing. Like, no, we can be a little bit more specific, even on the front end, to have a better sense as to what that child, how they're actually reacting, and then try to provide something that is more targeted to them, but then certainly nowhere near what can be done within an evidence-based trauma treatment framework for some of those different types of profiles as you described.
Thank you to both of you. I know that Slatina alluded to the fact that we are at time. Well, we're happy to leave the session open if there's any additional questions. I know that Brooks and Slatina were great about answering a lot of questions during the chat as the session progressed. But if there's any additional, please raise your hand. If not, Brooks and Slatina, I just didn't know if you had any, you know, brief key takeaways that you want to say before we begin to sign off.
So I'm going to ask Slatina, like my question, because I think this might be we can end on this, which is like a lot of folks like, ooh, I don't want to get my folks trained in trauma treatment because it's going to burn them out and they're going to be awful and cranky and I'm going to lose therapists and stuff. And so like, Dr. Kostova, what do you like best about being able to do trauma treatment with kids, that you actually use an evidence-based trauma treatment, like TFCBT? Like, what do you like best about that?
Thank you for this question. I think I have a lot of answers, but I do think that it really acknowledges the elephant in the room, and it allows the child and the caregiver to finally give some vocabulary to work with that avoidance and really help them to shift from that idea of what happened to me is really awful. And now I'm thinking in all these bad terms about myself and the world, to this is part of my story and I can relate differently to that. And so I think that a lot of therapists are really scared to talk about trauma because they are afraid that these will re-traumatize the child or themselves, and so as you said, Brooks, avoidance is shared avoidance between the child and the therapist. But I think what I like the most in TFCBT is that really it's profound to see how once you provide that safe space for the child and the caregiver to talk about trauma, how actually we do see a significant decrease in symptoms and many other outcomes.
Thank you.
Thank you for this question. I see Pragati having a question.
I do. I have lots of questions for both of you. It's a really amazing presentation from both of you. I think there's always so much more we need to do in mental health, but I do have a question for each of you that I'd like you to maybe take separately. So, it always starts with training professionals from the time that they, enter the professional school, whether it's medical school or, in their psychology training. Are we starting to incorporate all of these new innovative therapies in these various types of, whether it's in social work, making people aware of what is out there and how we can be more effective with mental health? I feel like the US has become a pill pushing, that this has become more easy for people to treat with medication versus these therapies. So I would like to hear from both of you about how you see, if it has happened yet, or if it needs to still happen more, in starting with the training in residency and in clinicals, for people to start to think about this more, in our prevention.
I can start very quickly. Thank you for this question. As a foreigner living in the United States, I have to say that I do believe that here we are more advanced in terms of providing trainings and talking about trauma. And I do know that there are so many countries out there who need that training much more. And it's almost like here we're taking a little bit for granted that we're receiving all these even free trainings in TFCBT and trauma-informed care. But I can totally understand other people from other countries that are joining. And actually, me and Brooks, we are collaboratively working with implementing some of the trainings that NCTSN created for childhood trauma within psychiatry and pediatrics, particularly within the residency in psychiatry and pediatrics, because what we are finding here is that people talk about trauma, but it's still very fragmented, and still we are using different terms and different ideas, even though the concepts are similar. And so one of our goals at UMass is to sort of create a curriculum that it's unified, that uses the same language, and that we can bring together pediatricians like Brooks and psychiatrists and psychologists like me speaking the same language and giving people really practical tools. What can you do right there in the office with the pediatrician? Or if you are a police officer, we are working with any type of professionals that are working with children. What can you do? How can you bring more awareness? And instead of naming that kid as, what's wrong with you, to ask yourself, what happened to you? And why do I see? What am I seeing? And I will hand it back to Brooks.
The only thing I'll just say, we have so much to do in every field. And there's these kind of shining points of light across the country, the United States. Victor Veith, the development of the CAST programs, which are in, I think, dozens of universities and colleges across the country, are ways to try to instill more trauma education within kind of undergraduate and graduate level schools. But really, there are no requirements to be a pediatrician or to be a child psychiatrist to actually have any meaningful understanding on childhood trauma. Period. That is just, you do not need to know that in order to graduate from pediatric school, whatever that is. So, I think that there's so much has been created, and we've learned so much over the last 20, 30 years, but our processes are still grounded in what we were doing in the 1950s and 1960s. So I think that there's a lot of opportunity And yes, our core curriculum project and trying to figure out how to train child psychiatrists, that's a baby step towards this. But I think it also, it speaks to a larger issue of workforce education. And then if you want to keep going backwards, it's undergraduate education. And like, well, if it's this prevalent, we probably should be teaching this at least in high school, if not earlier. Like, you know, this, you should not be graduate school the first time you hear about ACEs.
Yeah,
So,
that's true. Okay, put that on your to-do list.
Yep.
Yeah.
Thank you both.
The only other thing in chat that I don't know if you want to briefly address, or if you two need to go, I know you're very busy and what you're doing, but was this whole layer of children with disabilities and how these tools and programs, how you layer in, you know, whether it's nonverbal or just kids with autism, or, you know, is that addressed at all in what you presented today?
I can start talking about TFCBT, and I will put in the chat, there is a great resource, again, part of NCTSN, that a group of people that worked a lot on adapting TFCBT for children with developmental delays and autism. I would say that it's absolutely possible. We do see that it can be implemented with those type of kids. And again, it has to be tailored in a way that it's more deliverable for them. So using more visuals instead of abstract terms, engaging more the caregiver, right? Translating more those concepts in a way that that child can understand them. But there is actually a great webinar that it's talking about TFCBT and children with developmental delays. So again, I think that with the appropriate strategies and interventions, it can be definitely delivered to those kids.
And I did put a link into one of the Stride Center that Dr. Kostova is talking about, one of their handouts around autism and intellectual disability and trauma. They really are the world-renowned experts in this. And they actually advised us when we were talking about our trauma screening and identification, how can we best adapt our tool to meet the needs of the autism and IDD population? And so, like, I mean, I think that there are really smart folks who are working on this and recognizing that neurodiverse individuals respond to trauma in different ways, and we need to take different approaches, really is critical. But there is so much work to be done in that area as well. But it doesn't mean we can't do something. So I think that, you know, just because there's a lot of work doesn't mean we don't have some good starting points. And they really have wonderful resources specific to this population.
And this is one of the other myths, just last thing to add, there was a research that NCTSN did with clinicians who are saying that basically in their clinics, they wouldn't even take a child with developmental delay or autism spectrum disorder because they're afraid that they're not trained well enough to deliver trauma-informed care to those kids. And again, we see from research and data and clinical experience that this is really not true. And you know, models like TFCBT can be adapted for those kids with success. So yes, there is still a lot to do, but there are also a lot of things that are already done out there and can be really well implemented.
Thank
Thank you, Brooks, for the link.
I just want to offer a heartfelt thank you to both Brooks and Zlatina. The demand for this webinar was kind of record breaking for ISPCAN. If it tells you, you know, how deep the need is to break down these silos of information and to bring back best practice and data, you know, proven programs, you know, to all corners of the globe. So again, just the sincerest thank you for your time and for your commitments and for your sharing of what you do and what you do well. And just a reminder to everyone that they'll receive a recording from today's webinar. Any links to any resources, we'll pull some out of the chat that Brooks and Zlatina shared and the audience shared. If there's any additional, you know, resources to our two presenters that you'd like to share with me, I'll make sure they go up in the follow-up email as well. And we'll be sending out the recording hopefully by tomorrow morning at the latest. And just briefly, this webinar is part of our prevention campaign, which we're nearing the end of as we hit World Day for Prevention of Child Abuse, which is the 19th. It's coming up this weekend. And we still really encourage all of you to engage with us at the hashtag below, Rise Up to End child abuse. Again, we've been sharing tips, tools, best practice from all of our country partners from really every corner of the globe. And this, again, this presentation today was part of that prevention campaign.
Thank you so much also from my side, from everyone who joined.
Thank you. And if you're not a member of VISPACAN already, please consider joining us so we can keep great presentations and resources like what Brooks and Zatina presented today free of charge to anyone who registers. So again, Zatina, Brooks, thank you so much. Thank you to our audience and again to a very engaging chat. We'll make sure that we get that to Zatina and Brooks as well. So if there's any open-ended questions or unanswered comments, that they will have access to be able to do that offline.
Thank you so much.
Yeah, thank you.
Thank you
Thank
to
you
everyone.
both.
Bye.
Thank you.